This program is brought to you by Emory University.
You guys want to get started? So this is the curriculum for this year for the EP talks, and this is kind of what Dr. Bott wanted us to talk about. So if there's other things that you would like us to talk about, let us know. We're happy to change it up, but I think this is the schedule as of now. So unfortunately, I lost my USB drive with my talk on it, so this is an old version. I don't know. There haven't been a lot of new updates really on any of these hereditary syndromes, but these are the ones that we're going to talk about. Long QT syndrome, short QT syndrome we'll just briefly mention, Brugada syndrome, CPVT or catecholaminergic polymorphic VT, and congenital AV block. And I have to admit, these are probably the least favorite types of patients that I like to see, because I'm always concerned that, I think everyone is kind of concerned that they're going to miss something and something bad is going to happen to these patients. And they're often young, healthy, otherwise healthy patients with potentially disastrous outcomes. So the key for managing these patients is just to go by what very little evidence we have in terms of guideline-based management for these patients. There are a couple slides on here that I'll point out that if Bott, we always submit test questions for the end of the year exam, and he picks from those questions. So I will give you some key slides that the questions will be coming from if you want to doze off and then pay attention at those particular points. So when we see these patients, a lot of things are useful, a lot of things are not useful. The history is the most important thing. So when someone has syncope, and usually these syndromes they manifest as arrhythmias with syncope. So the history is the key. And if someone has syncope and they're out for 20 minutes, that's not one of these arrhythmia type conditions. That's some other probably supratentorial type syncope. But when someone has malignant syncope, particularly during exertion, where there's suddenly lights out and then by definition must come back very quickly, or receive CPR, or receive a shock from an AED, that's a red flag that something real is going on. So exertional syncope, the exam is almost always normal in these patients unless they have some sort of concomitant musculoskeletal syndrome type findings, which are seen with some of these conditions. But usually these are otherwise very healthy people, and their echo and their exam is going to be normal. Family history is important, and when you take a family history, when you're trying to tease out one of these conditions, talk about specifics with the patient. So did anyone die at a young age? A lot of times people were told that their uncle died of a massive heart attack. That's usually the case. He was out shoveling snow and died of a massive MI. Did they get an autopsy? Did they really have an MI, or was it just some guy that collapsed dead from a channelopathy? Someone dying suddenly at age 80 is probably not one of these things. But ask about things like drownings, people who die in car accidents. That's a big miss for families. They just know that someone ran off the road and died. If they were the passenger, it doesn't matter, but if they were driving, that's important. Family members who've had seizures, that's a common thing that we see. Or weird accidents. Like, I always ask if anyone's ever fallen off a roof or fallen off a ladder, or had, particularly clumsy family member that is actually just passing out. And then the EKG is really the critical thing. Genetic testing is useful for some of these conditions. It has varied yields depending on the condition that you're testing for. We'll talk about that with each of the conditions. So there's a zillion different channelopathies. And a lot of these slides are from the Mayo slides. Have you guys reviewed the Mayo slides yet? So a lot of these slides I've hijacked because Mark Ackerman up there at Mayo is kind of a world-renowned expert for these types of conditions. But we're only going to be talking about the very common ones. One thing of note, when we talk about long QT syndrome, that can be broken into two categories. There is the Romano-Ward syndrome and the Jervell-Lang-Nielsen syndrome. You can forget about this one. You'll almost certainly never see it. That's an autosomal recessive long QT flavor. And because it's autosomal recessive, it tends to be severe, and those patients are often deaf. And they usually have really bad arrhythmias. So it's not real common. When you guys hear about or think about long QT syndrome, you're talking about Romano-Ward syndrome. That's an autosomal dominant condition that causes run-of-the-mill long QT syndrome. So this is Ackerman's record EKG for long QT interval. I think it's in an infant or a young patient, and it was read as normal because these were read as P waves. And so you can see how, if you glance at this or if you just look at the computer interpretation, you may start to try to diagnose some sort of atrial abnormality here. But this is actually the QT interval. And a lot of times when it's this long, people will get 2-to-1 AV block because the ventricle is still refractory by the time the next beat comes. So one cause of 2-to-1 AV block in infants is actually long QT syndrome. So that's obviously a clear-cut diagnosis. This is a real-life patient of Jerry Lutz who was having recurrent syncope and was having this on his EKG that they happened to catch in the hospital. And this, I think, was actually medication-induced, but you can see the prolonged QT interval, and then this is the clinical rhythm, which is torsades. Usually, it'll have little salvos like this that terminate on their own. It's really not, the vast majority of episodes of these torsades do not end up with true ventricular fibrillation. So congenital long QT syndrome is characterized by patients with syncope, sudden death, and then seizures, which is usually a misdiagnosis. So these patients get diagnosed with seizures, they get put on medicines, it doesn't work because you're not treating the problem, they have another episode, they get switched on medicines. And they can have seizures as well, but talk to the patient and you will, you know, sometimes a neurologist just hears about a spell and says, oh, you probably have seizures, put you on medicines, but talk to them. Swimming is a common trigger for these things, or at least a common situational example that they give for an episode of sudden death, and we always wonder why that is. My theory is that the consequences of a arrhythmia when you're swimming are higher, and so you're more likely to have a bad outcome if you're in a body of water. There's some theories that swimming in cold water may influence the autonomic tone of the heart and somehow make you more predisposed to have an episode. But if you fall dead on the ground, you're probably okay. If you fall dead in the water, you're going to have trouble. This is probably, I just put this together this morning when I realized I lost my USB drive, but this is a slide you may want to remember for the test. There are a dozen or so types of long QT syndrome. There's really only 3 that we ever see clinically, with rare exceptions, type 1, 2, and 3, and of those, type 1 and 2 are the most common. And the trigger for these, which again is a classic trigger, certainly not the only type of trigger, but exertion or exercise for type 1, swimming or peripartum patients for type 2, and then patients who have episodes during sleep, think about type 3, because these tend to be bradycardic mediated spells. And then the gene mutations that are most commonly associated with these types, KCNQ1, KCNH2, which is otherwise known as the HERG gene. Anyone know what HERG stands for? Any basic science people? So human ether agogo related gene. If you hear HERG, it's the same thing as KCNH2. And then SCN5A, which is a sodium channel, is the most common variant in type 3. When we get gene testing for these patients, they don't just test for these gene abnormalities. There's a dozen or so genes on the panel that they test for. We'll talk a little bit about that. So this is someone with genetically proven long QT syndrome. The QT interval is corrected at 475. The way you measure the QT interval is important. So you want to take the longest QT interval that you see on the EKG. With sinus rhythm, it tends to be very much the same. With atrial fibrillation, it's much more challenging. We take the average of 10 or so beats. But with sinus rhythm, you take the longest one. It's often in the precordial leads, the lateral precordial leads, V5, V4, sometimes in the inferior leads. And you take the down stroke of the T wave, and wherever it crosses the baseline, that's the end of the QT interval. You do not count the U wave most of the time. That doesn't count as part of the QT interval. So you have to kind of commit to where you're measuring the QT interval and take your measurement based on that. The computer does a pretty good job of that, but you can see that if you were to look in a lead like this, it'd be really hard to tell. If you look here, you have a really clear downstroke of the T wave. Wherever you get the longest one, that's your corrected QT interval. This is someone with genetically proven long QT syndrome, and the QT is normal. And that's important because people with long QT syndrome can have normal EKGs, even if they have genetically proven gene mutation and they have clinical spells, their QT interval can be normal. And so this is the Mayo registry that looks at normal patients, males and females, and a good rule of thumb for males, the upper limit of normal is 440. For females, 450. If you want to just remember 450 as an easy way to think about the upper limit of normal for a QT interval, that's a good round number. And these are their patients with genetically proven long QT syndrome, and you can see there's a sizable 25-30% overlap of abnormal patients who have normal QT intervals. So normal QT interval does not rule out long QT syndrome, nor does a prolonged QT interval rule in long QT syndrome, because we can all prolong our QT intervals in certain situations. So there's a host of classic appearing T waves for long QT syndrome. The ones that are important are long QT1, which looks like hypokalemia. So the T wave tends to be really broad, low amplitude. So if you see something that looks like hypokalemia, it's probably long QT1. Long QT2 has this classic notching in the T wave. Sometimes it'll look like this. Doesn't mean it has to, but if you see that, think of long QT2. And then long QT3 is the other kind of classic one that looks like hypocalcemia. So the ST segment is isoelectric and long. The T wave looks normal, but it's just later in time, so the QT is longer. Exactly like hypocalcemia looks like. There are not a lot of diagnostic tests that we do. EP study is completely worthless for long QT syndrome. We get patients referred for that all the time, and there's no role for EP testing in general. The epinephrine test is something that we do, and basically we just give increasing doses of epinephrine for 5 minutes and measure the QT interval at the end of each dose. And a lot of times what we'll see is kind of a peak around here, and then it may shorten again here. And if you see an absolute QT increase of 30 milliseconds, that is abnormal. That might be something you may want to remember for the end of the year exam. 30 milliseconds is abnormal. If a normal person is put on epinephrine or exercises, the QT interval should shorten. That's a safety adaptation that the heart has. Patients with long QT syndrome do the opposite, and that's why they have exercise-induced syncope. And it's pretty predictable for long QT1. So they tend to have longer baseline QT intervals, not surprising. And almost always their QT interval will increase with epinephrine. And again, it's not always at the max dose, it's any time during that infusion. It's not helpful for other types of long QT syndrome. So epinephrine challenge is only useful for long QT1, and as it happens, that's the most common type of long QT syndrome. So it catches a lot of patients for us. So this is a picture of the potassium channel that we have in our hearts. And there's several components, like all transmembrane proteins. There are these transmembrane components which make up the core of the potassium channel. Potassium channel is 4 of these subunits. And then you have these tails of the protein that sit inside the cell. And these are the mutations that have been identified just on the potassium channel alone, not to mention the sodium channel. And so when we get gene studies back, we'll see abnormalities of some location along this protein, and I don't pretend to know all the details of these because it's pretty complex stuff. But we do know that mutations that occur on these components that sit inside the cell tend to be less malignant than mutations that impact the transmembrane component. So that's kind of a key item for an end-of-the-year test. If you have a mutation of the transmembrane component that's actually involved with potassium moving through the membrane, it tends to be more malignant. And the gene test will tell you that. This mutation is associated with bad outcomes, or this intracellular component tends to be not associated with bad outcomes. So when we get gene testing, most of the panels now look for 12 genes. We use a company called GeneDx, which you just give them a tube of blood and send it in about a month or two, they'll give you the results. For long QT, it's pretty good. It's 75% sensitive. That's as good as it gets for these types of gene testing. And we can talk about the strategy for gene testing. Really, the key is if you have someone who's had an episode of torsades or sudden death and they have a prolonged QT interval, those are the people you want to test. You find a gene and you can test the first-degree family members for that particular gene mutation. And then they either have it or they don't, and they're not worried about growing up if they're going to have issues. We can get tricked. I have a patient who's a nurse here in the hospital who has long QT syndrome, who has a KCNH2 gene mutation. She's had clinical episodes and has a QT interval of like almost 600 milliseconds. And so when her parents came in, her mom has had like 12 members of her family die before age 40, going back to uncles and aunts and grandparents. And then her dad's like, nah, no one's ever died in my family. So we tested the mom and her gene panel is totally normal. So now, surprisingly, the dad's family, this had to come from somewhere. So unless her mom isn't being honest with her father, it's coming from the dad. And so family history is important. Her mom's family history was probably the most impressive I've ever seen, but her gene panel was normal. And then if it's normal, if someone has clinical long QT syndrome and it's normal, that just means that we haven't identified the gene that's causing that patient's particular problem. And then you don't have to test the family with gene testing because whatever genes they have, they've inherited from their parents. So when you find it, look at first-degree relatives and then start to go back in the family tree because it has implications all the way back through the family tree, not just the patient that you're taking care of. This is kind of a classic tool. Quite honestly, I don't really use this, but it's a test type tool that you can use, and there's these high-risk categories. If your QT interval is greater than 500, that's a high-risk situation, particularly if you have long QT1 or 2. And the American US guidelines, AHA guidelines, are a little bit different from the European guidelines. The patient I told you about, the nurse who had a QT interval of greater than 500, she has long QT type 2, and was never on beta blockers, so the American AHA and ACC guidelines recommend no ICD in that patient. The European guidelines recommend an ICD in that patient, and she and I were both kind of spooked by this heroically long QT interval, so she opted to have a defibrillator implanted. And then long QT3 in men is a high-risk subgroup. So remember, really long QT intervals and long QT3 with men are high risk. And then in general, patients with long QT type 1 with a QT interval of less than 500, those are relatively low risk patients. You don't have to remember all these little subsets. Just remember the super high risk, relatively low risk patients. So treatment, avoid QT prolonging medications. And so this is a website that they use. I use lqts.org. Pick a website that you can remember, write it down, give it to the patient, and just keep in mind that they need to remember to avoid those medications because they tend to be prone, particularly long QT type 2 patients tend to be prone to medication-induced torsades. And you know, the other challenge with these patients is someone will get like a infection or something, they need to use antibiotics, and the doctor will say, send them to the cardiologist to treat whatever infection because they have this. Any doctor can prescribe a medication, they just need to be sure it's not a big offender with these things. And then beta blockers, that's really the mainstay of treatment. And another test type question is what beta blocker to use. Nadolol is the beta blocker of choice. It's not commonly used, so a lot of people aren't familiar with it, but it's a very well tolerated beta blocker. It's once a day. And the reason it's useful is because it has a very long half-life. And so you avoid peaks and valleys of beta blockade that come with things like metoprolol, which is common. Give them metoprolol. Don't use metoprolol, use nadolol. But beta blockers are crucial. The question is, do we use that in long QT3? And that's a debatable thing. You'll never get tested by that on the boards because no one really knows the answer. Remember, long QT3 tends to cause spells during sleep and during bradycardic spells. That's why beta blockers are a little bit controversial. Here's someone on Levaquin that we saw in our EKG stack in the hospital. This patient then we consulted on, and they indeed had a KCNH2 mutation, asymptomatic. We just told them to avoid medications that can prolong the QT interval and put them on beta blockers. So most patients with long QT syndrome don't need an ICD. The vast majority of patients do not. So the people that do are someone who's survived sudden death. That makes it pretty easy. If they can't tolerate beta blockers, or if they're having spells on beta blockers, that's an indication for a defibrillator. And when we talk about spells, we mean real malignant syncope. People with long QT syndrome can have vasovagal syncope like anybody else. So real syncope is crucial. If they have a really long QT interval greater than 550, consider it. Positive family history of sudden death, we don't usually use that as a indication for defibrillator, but it may sway you, or it may sway the patient, or you and the patient. Long QT3, because the medication options are relatively limited, and then these rare things that you guys will probably never see. But the big things is just aborted sudden death or recurrent episodes on beta blockers. The routine treatment is put them on beta blockers, and the vast majority of them do well. And then exercise limitations, that's the other thing. So what type of exercise can they do? These are young patients, a lot of them are physically active, and we say don't do competitive exercise, or what does that mean? The guideline I usually give them is a heart rate of 130, tends to be a safe guideline. And now with Fitbits and your Apple Watches, you can bet that they'll have a way to monitor their heart rate real time. Short QT syndrome, I'll mention it just so you are aware that it exists. It's the opposite of long QT syndrome. So long QT syndrome remember, is gain of function of sodium channel for long QT3 or abnormal loss of function mutations for the potassium channels, the result of which causes prolongation of the QT interval. Short QT syndrome is the opposite. Most of the time it's gain of function, potassium channels, and these patients have ventricular fibrillation as their clinical rhythm. Never seen a case. I thought I saw a case, but his gene panel came back normal. So CPVT is also something that we don't often think about, but it's relatively common in this field. And again, if you have a young person who is otherwise healthy and collapses during exercise, and their echo is normal, their exam's normal, they have almost certainly either CPVT or long QT1. You can kind of use those two as your top of the list things. These are the types of rhythms. Most people have something like this where they have all sorts of PVCs and then they ultimately go into ventricular fibrillation. This is the classic arrhythmia. Does anyone know what this is called? Bidirectional VT. I've never seen it, but on the boards, if they give you an example, it'll be something like this that then ultimately fibrillates. Does anyone know another cause of bidirectional VT? Dig toxicity, good. So those are the two common things. And CPVT is a mutation of, oh, we have that slide there. So bidirectional VT, common, no. Classic, yes. So again, these are people, normal hearts, normal exams, exertion-related syncope, exactly like long QT type 1 in particular. So you guys remember the ryanodine receptor? Everyone remember that? I gave a talk to the med students the other day about all this calcium handling in cells, and the way that muscle cells and cardiac muscle cells in particular take an electrical impulse and convert it to mechanical contraction is by calcium. And there's several mechanisms by which it does that, but one potent mechanism is when calcium comes into the cell, after voltage-gated calcium channels open, it triggers the ryanodine receptor, which dumps a huge load of calcium into the cell from the sarcoplasmic reticulum, and that's the bulk of the potassium load that causes contraction of your sarcomere. And the classic, that's called calcium-induced calcium release, by the way. The classic mutation in CPVT is a ryanodine receptor mutation that makes it leaky for calcium, and so there's a chronic overload of calcium in the cell. The cell is cycling faster than it ought to, and you have an arrhythmia. So this slide is out of place, but these are the triggers that I mentioned earlier. Long QT 1, 2, and 3. Remember, exertion and swimming are classic exertional type symptoms. Postpartum or peripartum syncope. I have one patient who's had 2 episodes a couple months after giving birth to 2 children, and she has long QT 2. And then either sleep or auditory, the alarm clock type syndrome where people get startled, that can be long QT 2. Long QT 3 is also sleep or bradycardia. So CPVT, the indications for ICDs are similar for long QT, aborted cardiac arrest or intolerance of treatment. The treatment is calcium channel blockers and exercise restriction. So these are exertional related arrhythmias. You guys all know what this EKG is? Pretty classic Brugada syndrome. This was a patient who, we used to do tele rounds that we don't do anymore because of the tele system that we have now, but there was a patient that was in the hospital. He had I think cutaneous T-cell lymphoma or some skin issue and was in with cellulitis and bacteremia and fever and arrested one night. And we were looking at the telestrips and we see this telestrip of VF, and it was like patient complains of lightheadedness, and then they just kind of tucked it back in there, and no one knew that he had VF that self-terminated in the middle of the night. And he was febrile at the time. So we went and saw him, and he had, this is his EKG during his fever that they got just coincidentally. So he had a classic example of Brugada, survived cardiac arrest in the hospital without anyone knowing it until the next morning. And no one probably would have known it if we didn't look at all those telestrips. So I fear what we're missing now that we don't have the ability to do that. But this is one of the few patients I have with Brugada syndrome. And so there's a couple cardiologist brothers in Spain named Brugada who described this disorder 30 years ago. It's more common in men and it's more common in Asians. And it's often one of the classic times for it to occur is during sleep, causes ventricular fibrillation. Sleep or fevers are the classic triggers. And so if you have a man in Laos who dresses up like a woman to go to bed, that's actually a real thing to try to prevent this type of thing from happening. Sleep and fevers, though, would be the key things that you may want to remember for end of the year exam. EP study, we don't really know what to do with EP study. There's two camps for the Brugada syndrome. There's the Brugada camp, and then there's the Silvia Priori camp. And depending on who you ask, they say everyone needs an EP study or no one needs an EP study, it's worthless. So it's something that the board should never test you on, except for the fact that it's controversial maybe. The one role of EP study is there is some data that if you induce VF during an EP study, that patient's more likely to have ICD therapies if they have an ICD, but it has no relationship to mortality. The other thing is if you have very short refractory periods that you can measure during an EP study, those patients are more likely to have arrhythmias and ICD therapy, so long refractory periods are better. But these patients, in general, don't benefit from EP study. So there's several different flavors of the EKG. The only thing that's diagnostic for Brugada syndrome is really spontaneous type 1. You can induce Brugada pattern by either shifting the leads 2 rib spaces upwards or giving them a sodium channel blocker like procainamide or flecainide and inducing this pattern. But spontaneous type 1 pattern is the classic diagnostic pattern. There's type 2s and types 3s. So type 2, this is type 1 where it has no ST segment. The J point is elevated and it goes right into the repolarization. It looks like a right bundle branch block and it has to be more than 2 millimeters elevated. Type 2 does not have that but has a bifid ST segment in V2. And then type 3 looks like type 1 or type 2 but doesn't meet the diagnostic criteria for it. The only one you need to remember is type 1. So SCN5A is the classic mutation. This is a loss of function for SCN5A, so it's kind of, you can think of it as the opposite of long QT type 3, although that's not entirely correct. And there's actually, we know that this is, even though it's the classic example, it's actually the minority of cases. It's about 30 to 40% of cases have this mutation. The gene testing is pretty pathetic for this. So a lot of times we'll get it if it's going to help family members, but most of the time it's a bust. It's important to talk to your patients about that. Gene testing is a messy field. A lot of times it brings up more questions than it answers. So we don't really rely on it for diagnostic purposes, but if you do find the gene, then you can easily test the family members. Do they have the gene or not? And that will relieve anxiety in the other family members. So indications for ICDs in Brugada syndrome, again, most people don't need defibrillators. Quinidine is a medication that we use to decrease episodes of ICD therapies. The way quinidine impacts Brugada syndrome is very complex because it's counterintuitive. It's a sodium channel blocker, so you would think to give that to a patient with a sodium channel loss of function mutation would be counterproductive, but it has potassium effects as well, which is why it works. But if someone survived cardiac arrest, they get a defibrillator. If they have spontaneous EKG findings and malignant syncope, so type 1 pattern, spontaneous, and syncope, those patients tend to benefit from ICDs. And then no one knows about EP studies, so you shouldn't really get asked about that. The last thing is congenital AV block. This is a patient who it was a little bit comical. He's had a liver transplant and was in the liver transplant clinic, and they noted bradycardia, so they got an EKG and then sent the patient home. And then the guy called and said, hey, you know, this is saying like really bradycardic. What should we do about this? And they couldn't get in touch with the guy for like 2 months. He was like AWOL, and finally came back in. He was fine, but he was like a 20-year-old, completely asymptomatic patient, and had this EKG. This is congenital AV block, and it's AV block in a person who you would otherwise not expect that. It tends to have a narrow QRS, so these patients are young. They tend to have vigorous junctional escape beats, and often they're asymptomatic. So there are some associations with maternal illnesses that can predispose patients to this. Usually presents in infancy or adolescence. Adults rarely. I have a few patients with this. Most of them get pacemakers. I have one patient who just refuses a pacemaker even though she's highly symptomatic. She can't walk up a hill, but she's like 50 and says she's not getting a pacemaker. But if they're symptomatic, give them a pacemaker. No one knows what to do with asymptomatic patients. There is some data that it may reduce the risk of sudden death from torsades. So if their junctional escape becomes less reliable, they don't tend to die from asystole, they tend to die from bradycardia related arrhythmias like torsades. In general, we recommend pacemakers for those patients. You can put them on a treadmill and see if their junctional escape accelerates with ambulation, but typically we don't have a real tough time convincing them that they need a pacemaker. So just in summary, if someone passes out with exertion, that's always a red flag. If they have structural heart disease, it's probably from that. If they have a structurally normal heart, it's almost certainly a channelopathy. And usually it's real syncope. So the one caveat to that is patients who pass out right after exercise. And we have a number of really healthy patients, and for some reason they're always runners, where they'll go running, and when they're done running, they'll run 10 miles and be fine, then they're done running, and 3 minutes later they pass out. That's usually a vagal episode where they're cooling down and they're dysregulated to some degree and they have a vagal spell. It's during the exercise that's the key. Always take a keen interest when someone tells you that they pass out during exercise. Or driving. Driving is another one that tends not to be a vagal spell. If you see someone that passes out while driving, although Ahmed admitted a lady the other day who had a 20-second pause on her monitor from a vagal spell while driving. But in general, driving is a safe thing. You shouldn't be passing out while driving. Family history and EKG are the keys. The genetic testing is useful to varying degrees depending on what you're looking for. EP study is almost never helpful. So most of these patients don't benefit from that. And most patients don't need ICDs. Exercise restriction, education, family history for other family members, and then medications like beta blockers, calcium channel blockers, and then quinidine for Brugada syndrome. Okay, any questions?
When you're deciding the ICDs for people, since they all come in with syncope, how do you distinguish syncope from sudden cardiac death? Since it's kind of, it seems like it's just one spectrum of the same rhythm, and just one degrades to the
Yeah, well,
How do
that's,
you-
if
Is
it's, mal-
somebody more prone to degrading to VF than somebody else?
well, they're the high-risk types that are. The first part is to figure out if the syncope was an arrhythmia or not. So if you have done all that and you say this was almost certainly an arrhythmia, if they've had syncope, that's sudden death that stopped. But if they weren't defibrillated or needed CPR, those patients are the ones you treat with medications. If they've not been on beta blockers, that's one thing that's pretty clear from the data. You put them on beta blockers, you don't put an ICD in those patients.
Once you're in Torsade, if you're one of the people that break or people that don't, is it just luck? What category you fall into? Or is
Yeah,
it
I don't
something more-
know if anyone knows that. Most cases of torsades from long QT syndrome will terminate. So most episodes are not fatal, which is good. And you guys have all seen that in the ICU where patients have torsades, and it's rare that it results in VF. So one way to look at it would be if you've fibrillated, which almost never terminates on its own, then you're going to have cardiac arrest and either be resuscitated or not, as opposed to someone who has syncope from torsades that then terminates and wakes up.
How often do you follow these patients up, like the frequency? Like, say for example, their QT is less than 500. Do you follow them short periods of time?
If they're asymptomatic, I follow them every year, once a year. And they know if they have a spell to call us. These guys are healthy and most of them are intelligent people and, it's a lot of education and I don't like it because it's like you're trying to predict the future in a healthy person and that what you're trying to predict is a really bad outcome. And it's not my favorite thing to deal with, but we've got to treat the patient. So you go by the evidence that we have. See them once a year, talk to them about the medications to avoid, and let them know if they have a spell to call you.
What's your strategy for patients that say have long QT and maybe you're worried about it, but the story is just, you're like, I don't know if this is really malignant syncope or whether it's vasovagal or something else. What's your strategy for that? Because I imagine it would be like poor form, to put a monitor on someone and then catch this,
Yeah.
malignant thing without any backup and something bad happens.
So use medicines, put them on beta blockers. That's kind of a safe first line thing. I have a patient exactly like that. She's got a QT interval of like 550, negative gene test. She's a dialysis patient. For some reason, we see this with young dialysis patients. One of the common things we get from renal transplant clinic is a prolonged QT interval in the absence of like hypokalemia or some obvious thing. And she has recurrent vasovagal syncope. And it's like, the first time I met her, I was like, oh man, she's gonna leave the hospital and die. And, it's terrifying. But her symptoms were classic. We did a tilt table and reproduced that. That's one of the few times I get a tilt table is try to reproduce what they have. The patient will tell you that's the same thing or that's totally different. I mean, a vagal spell is a very classic flavor that they have. And then sometimes you don't know. And so if you're uncertain and they're on beta blockers and you want to figure out what it is, put them on a monitor.
Now that most people are probably are going to be getting whole genome testing and just, get a red flag if they have an SCN5A mutation or something like that, and they have no EKG changes. Are people coming kind of through the back door that way? What do you do with those?
No, not commonly. I have one lady like that I saw a few months ago for the first time, and it was exactly that story. She had a family member who was fished out of a pool, arrested, defibrillated, rescued, got diagnosed with long QT syndrome type 2. And she was an ancestry.dna.com or whatever customer, and though this particular website, I don't remember which one it was, Ancestry or whatever, has a third-party company that they can send for really detailed testing, and she had her stuff sent to them and got diagnosed with the same gene mutation, a KCNH2 mutation. So I'm sure that we are going to be getting more of that. where people are casual genetic customers that find these types of things, and what do you do with it? This lady's asymptomatic, her EKG is normal, we put her on beta blockers and left her alone. But like everything with this new technology and constant rhythm monitoring, we're gonna find all sorts of false positives.
So this is going in, I know, I think Dr. Boyd gave the lecture on QT, like our EKG sessions over here, and he was saying, you know, that we see a lot of EKGs with people with really long QTs, and a lot of it's iatrogenic.
Mm-hmm.
But he was saying, you know, do you think there's credence that those people have probably, they're more prone to it because of some underlying unknown genetic
Yeah,
marker? And then, so I guess if you see that, I guess the way to fish that out is to try to get them off all of it. There's not, it's a different spectrum, is that fair
yeah,
to say?
yep. So this patient was it this one? I thought I had an
Even
EP.
though there probably is some underlying genetic thing that they're more prone to having that.
Yeah, I thought I had an EKG on here of someone like that in the hospital that we saw, who was on Levaquin and had never had a symptom, but because she was on Levaquin, it got unmasked. We tested her, she had type 2. The drug-induced long QT syndrome patients tend to be a type 2, subclinical type 2 patients. Because a lot of medications will prolong the QT interval. The reason it doesn't happen in everybody is because most people don't have a KCNH2 mutation.
Like, there's no mechanism like start going fishing for all this stuff when it's clearly iatrogenic.
Yeah, I think it depends on what the EKG looks like. If it's a 480 EKG and they're an asymptomatic patient, I wouldn't start digging, because then you're gonna scare people unnecessarily. If it's that EKG, it's more than 500, that's a red flag. 500 is kind of the red flag zone. If it gets more than 500, that's probably, there's an underlying subclinical gene mutation.
For Pulgada, there is no limitation in terms of sport. You diagnose somebody with Pulgada.
Yeah, I don't think there are any exercise limitations for Regatta. Doesn't tend to be triggered by exercise. Triggers are fevers and sleep.
If somebody with lung QT1 has progressed, then they would be able to get to 2005, but could you give epinephrine during that?
That's a good question. Probably. Well, I mean, epinephrine isn't really a treatment for VF in the field, so I guess if they were asystolic or had PEA, I would probably give epinephrine. But if they arrest, it's from VF, and usually we don't treat that with epinephrine. But that's a good question. That'd be really bad luck. All right.
The preceding program is copyrighted by Emory University.